Well, good day, everyone. My name is Earl Hirsch. I am coming to you today from the University of Washington in Seattle. And it's really a pleasure for me to be honoring Dr. Guthrie in this discussion on the impact of hyperglycemia and hypoglycemia on hospital outcomes. This is the University of Washington Medical Center. This is one of our three hospitals. This is the medical school, and the history of this land is very interesting. Before the building started in the 1950s, this whole area here was part of a 9-hole golf course. And you can see Husky Stadium, which unfortunately now remains empty with the pandemic, and the University of Washington here right behind. And again, I'm honored to be here today. These are my dualities as part of this CME. And this picture was taken, I was trying to think if this was 2 or 3 years ago at an ACE meeting of myself with Dr. Guthrie and Diane, who I have known for many, many years, and I knew of them long before I actually became friends with them. And again, I am truly honored to participate in today's symposium honoring Dr. Guthrie. He was a true friend, and he was such a big part of the entire controversy that he turned out to be correct about the impact of glucose control on the complications of diabetes. Now, why do individuals with diabetes have worse outcomes when hospitalized? That is not a controversial question. It is true. And the answer, we can go back to some basic science. And this is what happens, particularly in people with type 2 diabetes who are obese, who have hyperglycemia. On the left hand of the slide, you can see what happens at a more basic science level to cause more hypercoagulability. We have increased thrombin, increased fibrinogen, and we have a decrease in fibrin production. And this is why we see more DVTs, pulmonary emboli, myocardial infarctions in people with diabetes. At the same time, especially with hyperglycemia and obesity, we see low-grade inflammation, which further contributes to the hypercoagulable state. And we also get oxidative stress. These reactive oxygen species will lead to endothelial dysfunction. None of these are good news. And again, this is in the baseline state. Well, why is insulin deficiency, whether it's absolute or relative insulin deficiency in the context of hyperglycemia, so dangerous? Dr. Guthrie was fascinated with the topic of insulin and insulin administration. But as it turns out, when one does not have enough insulin at the cellular level, that's not good either. Because if we look at the combination of insulin deficiency and too much glucose, with insulin deficiency, we get more NF-kappa B. With hyperglycemia, we get more NF-kappa B. And this will go on and lead to inflammation. This is in the endothelial cell. By the same token, with insulin deficiency and hyperglycemia, we get this superoxide production, and this will lead to activation of this inhibitor of kappa B. And if you go downstream, you again get NF-kappa B production, but this is in the monocyte and macrophage. This leads to all of this inflammation. This is not a good thing. You can measure most of these cytokines, but I have to emphasize this is in the baseline state. So people with diabetes, at least from the get-go, before they come into the hospital, they are at a disadvantage with all of these cellular processes already going on. So going back now to 2001, there have been 5 ICU trials looking at what happens with intensive therapy versus standard therapy in the ICU. And when we start taking apart these trials, it's very interesting. The first one we call Leuven 1 from Greek Vandenberg and her group. This is a surgical ICU population, and they showed a reduction in mortality with a difference in glucose in the ICU of 50 milligrams per deciliter. Note the ratio of severe hypoglycemia in the intensive therapy to the control group was 6.6. We define severe hypoglycemia in the hospital as a glucose less than 40, different than the way we do it on the outpatient side. And then in Leuven 2, it was a medical ICU intervention. There was no difference in mortality, and the delta glucose was 52 milligrams per deciliter. Again, we saw more severe hypoglycemia with the intensive therapy compared to the control group. And then the two next studies, BICEP and Glucotrol, these were sepsis and medical surgical ICU patients. Both of these were stopped early due to too much hypoglycemia by the Data Safety Monitoring Board. Yet if you look at it, they actually had less hypoglycemia, at least the ratio of hypoglycemia, than the two Leuven studies. But the most important study, and the one that really changed our thinking the most, was the NICE Sugar trial. NICE Sugar was a medical surgical ICU study, and they actually showed an increase in mortality, the exact opposite of what the hypothesis was. But I want you to note that there were over 3,000 people in this study, but look at that severe hypoglycemia ratio. It is much higher than the other studies. But this was in 2009, and this has truly changed the way we think about glucose control in the hospital, and particularly in the ICU. So the targets that we have set from the American Diabetes Association and other societies around the world, is there a consensus? And I would suggest the road to consensus is true and lasting bliss, but is that true with our inpatient glycemic targets? Are we having true and lasting bliss? Well, let's look at this. The consensus right now from the ADA is 140 to 180 in the inpatient setting, but this is fundamentally based on observational data that patients with glucose above 180 have higher rates of infection and thrombosis. Perhaps not a surprise, but this is largely in the post-surgical ICU setting. This is where our consensus come from these post-surgical ICU patients. While there have been large numbers of observational trials, there have been no randomized controlled trials on general hospital wards that is not in the ICU, and most of these are powered for glycemic and not medical outcomes. So we don't really have the outcome studies for the non-ICU patients, yet we have this consensus of 140 to 180, which I would argue is not based on true randomized controlled intervention trials. But the observational data are quite interesting. Mercedes Falsiglia, early in her career at the University of Cincinnati, she looked at this large VA population, looking at mortality risks for all patients, and then subsets of patients with and without diabetes. Now, if you look, the odds ratio of mortality for those with diabetes in the turquoise, it increased as the mean glucose increased for those patients with diabetes. But look at those for patients without diabetes. For any given glucose, the odds ratio of mortality was actually higher if they didn't have diabetes than if they did for any level of glucose. We call this the hyperglycemia paradox, and we have seen this consistently in the literature. That is, those individuals without diabetes actually have worse outcomes than those people who do. But what Mercedes also showed is that it didn't really matter what the diagnosis was. We saw greater mortality with higher glucose levels for acute myocardial infarction. We saw greater mortality with higher glucose for ischemic stroke. And we saw the same thing with sepsis. So we do not know the A1Cs for any of these patients for those who had diabetes. And as I think you will see in a moment, knowing their pre-existing glucose control turns out to be quite important. So at least to most people, 180 milligrams per deciliter makes sense on the high side, but why is 140 the low target? And the real reason is from the nice sugar trial, everybody is so concerned, and I would say freaked out about hypoglycemia, that it was a safety issue. 4 to 6 times per day finger stick testing in the non-ICU, or even hourly for those on insulin drips, or every other hour in the ICU, resulted in unacceptable hypoglycemia. So that 140 number has more to do with safety than it does to do with anything else. And I think that's quite reasonable given our current technology and the way we've been for the last couple of decades. So this raises many questions in my mind. Is less than 140 better? We don't really know. Is 180 the right high target? I can't say that. Would it be possible to get euglycemia with CGM? I really don't know if that's possible, at least not yet. Why do those without diabetes consistently do worse for any given blood glucose? I don't know. That's another question. Now, I can speculate on all of these, but the real answer to all of them is, I don't know. Do those with diabetes and high hemoglobin A1C levels do different than near normal hemoglobin A1C levels? I mean, this to me is a fundamental question, Now, here's the good news about that last question. We actually have this very important signal study that was just put online a few weeks ago by Jamie Crinsley and his colleagues, an international group, looking at almost 5,600 ICU patients over a few years and almost 210,000 glucose levels, both central and point of care. Now, this should not surprise most people. If you come into the hospital with a hemoglobin A1C less than 6.5, if your glucose levels in the ICU are between 80 and 140, your risk of mortality is 10.5%. But if your glucose levels in the hospital are above 180 on average, look at the mortality. It's almost 36%. Well, based on what happens with inflammation and oxidative stress, perhaps that's not surprising. But here is what is surprising. Let's take a look for those individuals coming into the hospital with A1Cs above 8. Everybody at this hospital in Stamford, Connecticut had a baseline hemoglobin A1C. And if their A1C came in above 8, their risk of mortality, if their glucose was tightly controlled to 80 to 140 in the hospital, it was 15.7%, higher than the group at less than 6%, 6.5% for the same A1C. But look what happens if these individuals with poor control, defined as an A1C over 8, if their glucose levels were above 180, they only had a 5.2% risk of mortality. And you have to scratch your head on this. This kind of blows people away. And you think, well, maybe these people are just sicker, and that explains everything. But as it turns out, that's not the case. ICU severity of illness was looked at by the Apache 4 scores, and there was no difference in the Apache 4 scores or degree of illness for those with low A1Cs or high A1Cs. So this brings up quite a few questions, at least in my mind. For patients with hemoglobin A1C levels of less than 6.5, the higher mean ICU blood glucose was associated with an increased risk of mortality, but the opposite was true for patients with A1C levels greater than 8%. You had this association of lower mortality with the high blood sugar levels. Hypoglycemia was associated with increased risk of mortality for all patients, and this association was strongest for those with A1C levels less than 6.5. Now, this is quite important when we start thinking about what happened in nice sugar. We saw all that mortality in nice sugar with all that hypoglycemia. Very important. And finally, increased glucose variability was independently associated with increased risk for mortality in patients with A1Cs less than 6.5 and 6.5 to 7.9, but not for those with A1Cs greater than 8%. Now, I have a lot of things I could say and think about this glucose variability finding, but right now, it's just an interesting signal. I think it's worthy of further research. But again, more questions than answers. To start, why is a high A1C with hyperglycemia protective, while the same A1C with euglycemia or minimal hyperglycemia results, or at least is associated with, an increase in mortality? Can this observation be reproduced in a multi-center trial? Most with A1Cs less than 6.5 have prediabetes or normal glucose tolerance. Why is stress hyperglycemia and hypoglycemia more dangerous in this population with prediabetes or normal glucose tolerance? Very interesting and important question. Glucose variability is not well tolerated in those with low A1C levels. Are these patients more prone to the inflammation and oxidative stress seen with glycemic variability? It's a hypothesis, I think, that is worthy of further research. Now, I think it gets more interesting with this SHR, and I think this is going to be one of the most important things to take away from the talk. This is the stress hyperglycemia ratio. This is not new, and this is simply defined as the admission plasma glucose in the ICU, that one glucose, divided by the estimated average glucose, which is converted from the hemoglobin A1C. The hemoglobin A1C was converted to glucose with the ADAC study, which was published in 2008. First author was David Nathan, where we can get what the average glucose is from the hemoglobin A1C. And if you do this ratio of the glucose in the ICU when you come in to the estimated average glucose from the A1C, you get the SHR. So the higher the ratio, the greater the stress in relation to baseline glycemia. So what we are talking about is relative hyperglycemia or potentially relative hypoglycemia. So let's take a look at this. If someone has an A1C of 6, from the table in that 2008 paper, their estimated A1C, their estimated average glucose is 126. If someone comes in with an admission glucose of 220, their SHR is 1.75. By the same token, if their admission glucose to the ICU is 165 with the same A1C, their SHR is lower, they're less stressed. If their A1C is 9, and that means their estimated average glucose is 210, and they come in with an admission glucose of 220, now their SHR is only a little over 1, much lower than the first individual who comes in with an A1C of 6. And by the same token, if someone comes in with an A1C of 9 and their admission glucose is 165, their SHR is actually less than 1. So they're not stressed at all. Now, let's look at this. If someone comes in with an A1C of 6, their estimated average glucose is 126, but their admission blood sugar into the ICU is 400, they have an SHR of over 3. And by the same token, if they're at 9 and they come in with a glucose of 120, their SHR is 0.57, a very low stress. Now, this is a way to look at somebody, how sick they are when they're coming into the ICU, just based on the one glucose. And this is where, to me, it gets really interesting and really fun. Now, realize critical illness and inpatient mortality or ICU admission. If we want to go and look at this study in 2015, I want you to look at the SHR, the stress hyperglycemia ratio. This is mortality in the bottom line. This is ICU admission. And if we look at the combined here, you get this solid line. This is the higher the ratio, the greater the risk of critical illness, which is either ICU admission or mortality. I think that makes sense. But look what happens if you now separate it by hemoglobin A1C. This is in SI units, so 10 is 180, 20 is 360 milligrams per deciliter. But what you see here is for these individuals who have A1Cs above 6.5, you get a very different curve than those people with low A1Cs below 6.5. That is, those below 6.5 have a much greater risk of critical illness, mortality, or ICU admission at the higher glucose levels. Those above 6.5 have less of a risk. But if we now change this to stress hyperglycemia ratio, instead of glucose, the lines are on top of each other. The lines are literally on top of each other. If you look at this ratio, the risk of critical illness is the same because you are using this A1C metric in a different way, looking at the estimated average glucose. Now, 5 years later, let's go to 2020. If we now look at less than 6.5 versus greater than 6.5, and again, we see with the admission glucose, those individuals with A1Cs less than 6.5, they have a different mortality rate. But if we again put this with the stress hyperglycemia ratio, the curves are pretty much the same. It's the ratio that's important. So are we ready for this? Are we ready for this? Are we ready for precision medicine and individualized glycemic goals based on the previous A1C, or better yet, with continuous glucose monitoring, the time in range, the estimated GFR, myocardial function, and previous history of hypoglycemia from insulin use? Is all of this involved in how our patients admitted to the hospital will do? Maybe Robin Williams said it best. No matter what people tell you, words and ideas change the world. And what I've learned from reviewing this literature and now being part of some of this, these ideas are really mind-blowing to me. And this may be why those studies, including nice sugar, did not show what we thought they would show, because they were looking at people with all kinds of A1Cs, which were not even measured. So here's another way to look at the issue of precision glycemia in the hospital. Dr. Deming said, "In God we trust, all others must bring data." And that's what we need right now. We need data. And what I would say is preferably a randomized controlled trial using continuous glucose monitoring. And that's what we hope to do here in the near future. But how do we do? How do we do in the hospital right now, knowing what we know? Well, the last study that I can find on this was published in 2009, because unfortunately, after nice sugar, people seem to have lost interest in this topic. So it's been a long time since we've looked at this in many patients. And what this study showed with 126 hospitals and thousands of patients, if we look at the mean of the means, both in the ICU and the non-ICU, the mean of the means, that we see average glucose of 165 and 166. Not horrible when you look at that. But if we look at the percent of patient days with at least one hypoglycemic event, now it doesn't look nearly as good. 10% in the ICU are less than 70. You can see 6% less than 60 and so forth. In the non-ICU, we don't have as much. Remember, most of these, or all of these, are point of care glucose levels. This was before the era of continuous glucose monitoring. And if we look at patient day weighted means, what we can see is that almost a third of patients have their mean above 180, and almost 11% have their mean above 250 in the ICU. It's equally not very good in the non-ICU setting. The point here being that this was a long time ago and we didn't do well then. This was before the NICE sugar study, which was initially reported in 2009. So these are my anecdotal observations. The publication of NICE sugar at best made most healthcare providers more cautious about hypoglycemia, and at worst made them cavalier. Maybe that doesn't happen in Wichita, but this is what I have seen. Those who were not involved cannot appreciate the culture of improving glycemic control in the hospital at the time due to the previous randomized controlled trials. I think it's time to be honest when we think about inpatient diabetes now in the fall of 2020. We need a reality check. And this is what I see in the hospitals around the United States. And this is just a small sample. I see minimal attention to most people with their blood sugars, especially for those people who come in without known diabetes. It is not attended to. I see sliding scale insulin without any scheduled basal or bolus insulin. I will tell you that sliding scale definition has changed over the years, but at least in the traditional form of just giving insulin when the nurse has a chance to check the blood sugar, it doesn't work. Misdiagnosing euglycemic ketoacidosis. I've seen several of these just in the last couple of weeks because not stopping the SGLT2 inhibitor. Little to no understanding of transitioning from non-formulary to formulary insulins, especially with insulin degludec. Poor and non-standardized recommendations on how to dose insulin before procedures. I mean, this is something that is critical. You need to understand the difference between type 1 and type 2 diabetes. Not knowing when to do or asking for help for patients admitted on an insulin pump, on continuous glucose monitoring, and those individuals now coming in on automated insulin delivery systems. If you're a hospitalist or you're a resident in the hospital and someone like this comes in and you have no idea how to manage these patients, you need to ask for help. And I see this a lot. A well-intentioned physician who doesn't appreciate the patient is more knowledgeable about the insulin dosing than the physician and not listening to the patient or the family member. And I can't tell you how many times over the years I've had to stop disagreements, fights, moving into wars simply because there was poor understanding by the physician as far as the diabetes and insulin management. Now, I need to give a special shout out to the SGLT2 inhibitors because they are now being used increasingly for initiation for heart failure exacerbations in the hospital for those individuals with and without diabetes. So the concern about ketogenesis with these drugs in the hospital need to be understood. I don't know how many cardiologists are listening, but can every cardiologist differentiate type 1 from type 2 diabetes? My anecdotal observation is no. I have seen this over and over, both in the hospital and outside. And then all these practical issues with the use of these drugs in the hospital. What do you do when you need to order an FDG PET scan, for example, where you're suspicious about a cardiomyopathy, for example, from sarcoidosis? The patient's on an SGLT2 inhibitor, and now the patient has to fast to keep the glucose levels within target, both with and without diabetes. How do we deal with that? What is needed now in the fall of 2020 is understanding that the best evidence for the current time is glycemic targets of 140 to 180, with the understanding, like all of our data, this can change. Continuous glucose monitoring in the hospital to assist with these targets and perhaps new ones. And my colleague, Dr. Umpierrez, will talk about this. Standardized insulin protocols for subcutaneous insulin, basal bolus with correction dose algorithms, and not the classical sliding scale insulin. And one needs buy-in for the protocols from the nursing, nutrition, medical staff, ideally with a glycemic management team or somebody in the hospital to champion all of this to assist for difficult cases. And we all see these. Individuals on steroids, TPN, nocturnal tube feeding, and many patients with type 1 diabetes, pumps, and those individuals with atypical diabetes, and there are many of them. People have to understand this and be willing to ask for help when they get stuck. What else is needed? A better understanding of the SGLT2 inhibitors, and for that matter, the GLP-1 receptor agonists. When to continue, when to discontinue. Now, it's difficult to discontinue a drug that's given once a week now with most of the GLP-1 RAs. Nevertheless, this needs to be understood. One also needs a better understanding of all the new insulins, including the pulmonary inhaled insulin, and how to transition to formulary insulin. I know of no formularies in the hospital that have Degludec on the formulary. If you're interested in this topic, earlier this year, Dr. Boris Drasnin and I published an article about this in Journal of Clinical Endocrinology and Metabolism. It is a common problem. Better transitioning for patients to new insulin in the hospital. We have a transition clinic here in Seattle where patients who are started in the hospital can then come into our clinic for further education and assistance, because often these patients will get lost otherwise. And what we really need are randomized controlled trials to assess if this hyperglycemia paradox can be explained by the relative hyperglycemia and relative hypoglycemia noted in the data I showed you by the stress hyperglycemia ratio. So thinking about inpatient diabetes management since 1980, 1980 was the year I started medical school. Woody Allen said it best: if you're not failing every now and again, it's a sign you're not doing anything very innovative. I think we will be doing more innovative things, such as what Dr. Umpierrez is talking about today. Woody Allen made this quote, and I think it's very apropos to inpatient diabetes management. This is my clinic here in Seattle, and I thank you all for your attention.